So Fadia is a tenured professor of pharma. Anyway, Fadia is also my friend and my mentor, so I can call her Fadia. Yes. She's a tenured professor of pharmacoepidemiology and pharmacoeconomics in the Department of Pharmaceutical Services Research at UMB School of Pharmacy. She's also the executive director of the Behavioral Health Research and Policy Program and director of the Center on Drugs and Public Policy. Dr. Shaya is a co-director of the NIH Bioinformatics Core in the Institute of Clinical and Translational Research at the University of Maryland, Baltimore. She directs statewide substance use prevention programs with special emphasis on high-risk populations and pregnant women. Her team provides technical assistance to all public health jurisdictions in the state on strategic planning, building capacity, implementing and evaluating interventions to prevent prescription drug and other substance misuse and abuse. We welcome Dr. Shaya to the podium.
Thank you. Thank you very much for hosting me today and for hosting this wonderful IPE. There's no way we can do that alone. No school can do it alone, and no person can do it alone. But to tell you why we are here, I looked at some numbers, and we always look at the numbers and think, okay, these are numbers on sheets of papers or screens, but these are real people. So by the time we go to lunch break today, 6 newborns would have come to this world with neonatal abstinence syndrome. Just between now and lunch, whether you have lunch here or at Subway, it is real. So these are newborns. What it's going to cost us is $500,000 between now and noon. Just that spent on them. That's other than the human cost of it. And if any of you, please raise your hands, are or know a woman of reproductive age between the ages of 15 and 44, please raise your hands. Are or know a woman, exactly. So all of us are concerned with that. And also, 1/3 of these women of reproductive age would have taken a prescribed opioid in the last year. That means that if you are in a meeting and you are a woman of reproductive age and you have 2 others in the meeting, one of you has been prescribed and have taken opioids in the past year. So this is really very compelling. We really have a call to action here, and that's why I'm very pleased that we have this beginning of a conversation, and hopefully many more meaningful pieces of work can come out of this. I would like to stop here and thank Dr. Titus Glover for having invited me and made this perfect forum available. But I would like also to recognize our partners, friends, collaborators from the state of Maryland who are here today and who have also made our work possible with opioid use prevention and prescription and substance use prevention. So I would like to start with Shaya D. Please raise your hand. I want to thank you very much. Brooke Holmes, yeah, you can clap. And Brooke Holmes, also from the Maryland Department of Health, who would be speaking also later this morning. As well, I would like to recognize our team, Dr. Michelle Taylor, Dr. Apurva Pradhan, Nicole Silfon, Vanessa Michel, Sharday Jones, also some of our alumni who have moved on to other entities or out of state, Marianne Gibson, Meg Robertson, and the person who has made all of this possible, Larry Dawson, who has retired since then. Maybe after working with us decided to retire. But this is very meaningful work. We really take it to heart, and we consider these partnerships lifelong commitments and lifelong collaborations. For us, it's much more than a contract. It's much more than a statement of work. We really value these collaborations. And in fact, that's the only way we can do it, not only across our schools, but also in collaboration with the state, in collaboration with regulators, health systems, providers, and many of you who are representing different entities here today. So with that, let's move to the numbers because we are in academia and we can't run away from that. So the opioid use has quadrupled in the last 10 years. This is from Humana. So I have taken this. 1/3 of the insured population of women fill a prescription for opioid each year. Again, as a member of the School of Pharmacy, we are very conscious that the last point of defense is the pharmacy. This is where the legal prescriptions really get launched and get released into society. So we are very careful at looking at that point as well as, of course, how they are utilized. And remember, this is all about prevention. So everything I say today is going to give us ideas about the touch points of where prevention is going to be more impactful. And that's the conversation that I hope will continue throughout the day today, and then also in the days and months and years to come. Although years, I hope we would have solved that problem. Increased prevalence of opioid in pregnancy has led to 5 times an increase in the neonatal abstinence syndrome in the last 10 years. However, it is very interesting that a study has shown that only 20% of the births that are with NAS, neonatal abstinence syndrome, seem to be from mothers who are on opioids. So that tells us that there is a disconnect. If only 20% of the births that are with neonatal abstinence syndrome are documented as coming from women who have opioid use disorder, there is some disconnect, probably in underreporting opioid use disorder in pregnancy, and we will get to that and talk about the possible reasons for that. I mentioned about the number of neonates that equates to about 2 per hour, basically. Every hour there are 2 newborns, and probably this is data from 2012. Probably, unfortunately, it's much more now. Why we have those collaborations with the state? Not only because we are a state university and we care about our state, but because the burden is also shouldered mostly by the states. Because the burden also is affecting Medicaid population more so than other populations, more so than working populations, and more so than Medicare populations. In the state of Tennessee here, it's easy to talk about others, about 2/3 of neonatal abstinence syndrome cases were associated with legal prescriptions. So what does that tell you? These are not people going and getting it from the street or illegally. These are, and I don't want to fault the pharmacy, but these are prescriptions that are legal, that are leaving the pharmacy in all with checking every box. So we need to be very careful that out of these NAS cases, 2/3 are attributable to legal prescriptions. One thing we want to keep in mind is whether those prescriptions were written to the ones that actually took them. Because in one of our studies and other surveys, we have found that people are getting legally prescribed opioids, but legally prescribed to others. Might be family, might be grandparents, might be friends. So these are all the legal supply, but again, used inappropriately. And that's where we find that our role is in prevention. Please keep in mind, again, I will keep repeating that everything here is about informing us and informing, having that discussion about where are the touch points for intervening, for prevention, because that's the best way we can carry that. Again, remember, we are addressing this to prevent the intergenerational cycle of abuse. A baby born with NAS, the prospects of that baby holding and carrying a normal life or a healthy life or living to their potential are very dim compared to those born without NAS. So let's look at some of the demographics here to look at, where do these women, what age group do they belong in? We see here, based on SAMHSA data, that on the left to the right, these are all reproductive ages. You see across the board that there is more opioid misuse among younger women. These are 15 to 17. It's a very critical age, and they have their whole life ahead of them, probably more than one birth down the line. And this is the highest. So this is across green and white, green being pregnant and non-pregnant. Across the board, in general, they have higher misuse of opioids. The peak in general comes in the age of 18 to 25, again, the peak years. But look at the difference between green and white. We see that the prevalence of misuse of opioids is not very different between pregnant and non-pregnant in the younger age groups. Whereas 18 to 25, it drops, 35 to 44, by then, they figured it out, or somehow they figure out not to report it. We don't know. But one way or the other, these differences also are very concerning because we don't know whether it's real or not. Are they reporting, not reporting? Are they more conscious of what we'll talk about later on, stigma? But these are numbers that are not sustainable. We talked about Medicaid, and we talked about different demographics. So this is a breakdown, again, from SAMHSA by poverty level. And as you see, the prevalence of opioid misuse is much higher in the higher poverty levels on the left. So those who are below the poverty levels are tending to misuse opioids more frequently than those who are above the poverty level. And if you look also at the difference between pregnant and non-pregnant, there's a much lower difference among those below the poverty level. So if we put all of these together just with these two slides and think about prevention, and to prevent that intergenerational cycle of opioid abuse, we probably want to look at high school populations, college populations, or young adult populations, again, for women. Now, of course, we need to intervene everywhere, but to get the most mileage, we might want to start in the young adult populations and understand what is behind those numbers, what is behind these, and possibly also look at the federal poverty levels. Now, this is only just a cross-section 2 by 2, right? So there might be other factors that are playing into that demographic below poverty level. Is the information getting to people equally, same way? Is the dissemination of information, are the prevention programs equally reaching those below and those above the poverty level? Again, just to reiterate, this is affecting the state, it is affecting prevention program, it is affecting budgets. The last number I will look at here is by admissions, and the comparing any non-heroin opioid versus any opioid. The admissions attributable to non-heroin opioids are much higher than for any opioid, for any heroin. So let's zoom out of all of this and look across the nation. Across the nation, we note very stark variation in different states. And when looking at the map, we don't know. I mean, if I go around the room and ask, what does this mean? What does it mean? Why are some have higher prevalence of prescription opioid dispensing during pregnancy? Based on your field, based on your sources of information, the studies that you are familiar with, you might have different answers. But the bottom line is that 1.1 million women with completed pregnancy in the 46 US and Washington, D.C., so this is what this represents. There were about 1/5 of Medicaid recipients that filled a prescription opioid during pregnancy. And about, I would say, 1/3 was among whites, 20% among blacks, and about 13% among Hispanics. So this is the distribution. What we make of it, how we intervene, where we go into our prevention programs really has to be laid over the other slides that we have seen and respond to the state's needs and the state's, the understanding of the, what is happening in the terrain in the state. And we're very fortunate with the team that I have mentioned that we have that collaboration with the state, that we can not only look at data, but also validate it with real world evidence. Okay, so we have looked at this map and then thought, well, wait a minute, what's the difference between states other than we have regions? So we started looking at regions here. This is based on data that we took from IQVIA, which is a commercial database. So this covers all insured populations and that are working. Remember, a very far cry from Medicaid populations or under poverty level. And we have said that those populations are at lower risk for opioid prescription and opioid use disorders. With all of this now, still, we get a variation whereby we get a slightly higher prevalence in the Northeast of opioid use disorder. That's the third column. In the Northeast, a higher prevalence. However, proportionately, fewer of these women are taking medication-assisted treatment. So although in the Northeast there's a higher prevalence of opioid use disorder, fewer of these are taking treatment. What that tells us, and this is insured population. Remember, there are probably a lot of underreporting here. The interesting part is that we looked at the states and this map, and we thought, what's the difference between the states? We had done, and also with Dr. Titus Glover and others here, we had done some focus group interviews and asked pregnant women what was the barrier to accessing treatment, and not surprisingly, stigma was at the top of this. There was a strong fear, deep ingrained within women, and I guess everyone, but that deep concern was about losing custody of the newborn. And anything that could compromise that, even at the expense of their health, or they thought maybe the deferred health of the newborn, they were not going to be running into. So there was a lot of stigma. So when you lay this over criminalization statutes in certain states, we thought, well, maybe there is some concern there that the states that have criminalization will have lower reporting of maternal opioid use disorder, perhaps lesser access to treatment. So the yes here, legislation present, yes, are the states that have those criminalization statutes. And we found here that 0.07% versus 0.18% were reported as having an opioid use disorder. Now, it might be that those states, I don't know which way it goes. Maybe the states that have a criminalization statutes, and I'm looking at School of Law, maybe states that have a criminalization statutes actually are successful at preventing that completely, but we don't think so. Yeah? Okay, we don't think so. Okay, so we'll have that's a good segue. It was totally unplanned, by the way. But it is probably most likely in underreporting because of fear, and that makes it even worse. Now, with receiving medication-assisted treatment, interestingly, we find that they do receive proportionately more medication-assisted treatment than those in the states that do not have that criminalization. That might be undercoding, potentially, that there might be some practices that have readjusted so that women get access to treatment yet are not coded as having OUD, because that will trigger that referral to social services. But we can have that discussion with the School of Social Work as well and law. So I would like to end here, and I have 1 minute, with some of the challenges that we face. I will go quickly, only pick a few of them. There is a need for increasing screening during pregnancy, keeping in mind to keep the woman safe and the disposition of the newborn safe also. So let's keep this in mind. I will also like to touch upon the complexity, because it is really about the social determinants of health, improving access, and then putting some incentives in place to shift resources toward prevention. And I want to reiterate, if there's anything you want to take away from this, it is population health and prevention is where we can put most of our efforts and have it pay off. These are very young people who have their whole life ahead of them, and preventing that for them and future generations is the best payoff. The integration also is looking at data, so you can look at these slides, but bottom line, keep it evidence-based. Keep looking at the evidence, what is being produced. With our collaborations, we are poised to be also generating more evidence, and I look forward to discussing that evidence with you at the different breaks and have that discussion follow on. So thank you very much for that forum.
We have about 2 minutes for questions, and we have index cards which are floating around somewhere. So if your question doesn't get answered, or you have a burning question, just write it down, and we'll try to get the presenter to address your question before you leave today or in the future. So, questions? Dr. Shaya? Sorry. Dr. Shaya is available for 2 minutes of questions.
So I'll take a picture while you're...
Okay, she set the tone very nicely for the rest of the day, and we look forward to getting more questions from you. I'm sure many more will come. Our next presenter, if there are no more questions, any? No? Going? Okay. The next presenter is Dr. Katrina Mark, and Jamie Swidlikowski will be introducing Dr. Mark.
Good morning. It is my pleasure to introduce my colleague, Dr. Katie Mark. She's a board-certified OBGYN and an associate professor in the Department of Obstetrics, Gynecology, Reproductive Science here at University of Maryland School of Medicine. Dr. Mark provides full-scope women's health care in her own practice and is the medical director of the Women's Health Center at Penn Street. In addition to her medical practice, Dr. Mark conducts research in the field of substance use in pregnancy. She's served as the institutional principal investigator on several NIH-funded studies and has authored 30 peer-reviewed publications. So with that, I'm very excited to hear what she has to say, and I'd like to welcome Dr. Katrina Mark.
I'm not Dr. Mark. But we keep forgetting to ask you to put the pre-test towards the person sitting on the aisle, and I'm going to collect them now because otherwise it won't be a pre-test. Okay, thanks. And we need to demonstrate that we've improved some things in your thoughts, beliefs, or knowledge in order to demonstrate to the Center for Interprofessional Education that this was a good idea to do this. So please fill them out and I'll come collect them. Sorry, Dr. Mark.
No problem. Hi, I'm Dr. Mark. Can everybody hear me? Okay, I'll try to somebody wave to me if I get too far away from the microphone. So thank you for having me. I was asked to come today to talk about the opioid crisis, and how we got to where we are. As Jamie mentioned, I'm an OBGYN, and I see this every day. And for those of you in this room, you obviously understand that there's an opioid crisis, and this is something that we're trying to move forward from the history of what has got us to this point. So thank you already for being here. I know I'm preaching to the choir a little bit, but let's talk about how we got here. So opiates are not new. They've been around for centuries. So why all of a sudden in the past few decades have we started to notice this enormous opioid crisis, and particularly it affecting women? So the face of the crisis has changed a bit, but the actual, the essence of the opiates have not necessarily. So how did we get here? In the early 19th century, opiates were prescribed for women for a multitude of reasons, and they were mostly prescribed to women. Men's drug of choice was alcohol, women got opiates. They were prescribed for all sorts of female troubles, such as painful periods, hysteria, which is what they used to call PMDD, and actually, fun fact, or not so fun fact, that's where the word hysterectomy comes from. It literally means removing the hysteria, because people used to believe that all craziness came from the womb. In the early 19th century, they used to prescribe opium for this. 2/3 of the people struggling with opiate addiction were females, and they were almost all prescribed it legitimately by a physician. Eventually, we realized that this was a problem and that opium was addictive. And so what did they do? They created morphine and said, don't use opium. Opium's bad. Let's use morphine instead. So great. Now everybody got dependent on and eventually addicted to morphine. And that became known as soldier's disease. Everybody coming back from the war started taking morphine for pain, for all kinds of different troubles. And then eventually we realized morphine was a problem. So then heroin was created. For 8 years, heroin was actually over the counter, and it was considered to be less addictive than the rest of these drugs. So you can see this cycle just keeps continuing. We create a problem, and then we make a new medication and say, well, now I'm prescribing it to you, so this one's okay. The other one that the other people used to give was a problem. So then, after heroin, what happened? Oxycodone. So oxycodone and OxyContin are the new players on the market. OxyContin was marketed as a long-acting, slow-release opiate that had a low abuse potential and a low diversion potential. This was extremely, extremely aggressively marketed, mostly by the Purdue Pharma, which were the creators of the OxyContin, and this was actually approved by the FDA for long-term pain management, even though there's literally no evidence that long-term opiate use is helpful for pain management. But it was approved, and then it was prescribed by everyone. And this really made the opioid crisis take off. So heroin addiction was not a new thing, but it was really isolated to urban centers for a very long time. And some people from rural areas would drive into the city to get heroin, but most of the time it was big cities, urban centers where you really saw this addiction. But once oxycodone and OxyContin started being prescribed like candy, then all of a sudden you see it spread across the entire country. And now by 2012, there are enough opiate prescriptions for literally every man and woman in the country to have a month of opiates. So in a very, very short period of time, we increased our prescribing by, it quadrupled in a very short period of time. So unless you've been living under a rock, you probably heard about the Sacklers. And the Sacklers are the family that got just disgustingly wealthy off of OxyContin. And recently, there have been a lot of lawsuits about this, and they are being held accountable and having to give away some of their money and wealth. But the thing that I want to impress upon you today is that the Sacklers are partly to blame for this. Purdue Pharma did really aggressively market this, but they didn't do it alone. There was really an opening in the healthcare industry that allowed this to happen, and there are some things that we continue to do that are continuing to allow this to happen. So I think, although I do blame the Sacklers and Purdue Pharma, I don't think that we can leave that as our only scapegoat, because we really need to look to ourselves and realize what did we as the healthcare industry do to play into this, and what do we continue to do. So the Joint Commission has created, back about a couple decades ago, created the pain scale. And this got also very aggressively marketed, and doctors and nurses were taught that there was an epidemic of untreated pain, and that we were just being unethical, and we needed to treat people's pain better. And so pain became the fifth vital sign. And it was required that with your vital signs, blood pressure, pulse, temperature, you were also checking people's pain score. And they made this very handy-dandy little card that people look at to say how much pain they have. And the problem with this is that this smiley face in green says no pain. And anybody that works in medicine knows that no pain is a really unrealistic goal. So I do C-sections for a living, right? And after a C-section, people get very upset if they feel pain. And to me, that's a failure of the healthcare system, that I just cut your body and took a person out of it. The expectation is that you will have some pain. But we've really pushed this idea that no pain is the goal, and when you get to no pain, that's success. And so we just keep throwing opiates at people, expecting that we're somehow going to improve their outcomes, but it doesn't actually improve outcomes. And so this this combination of the aggressive marketing of these medications and the all of a sudden switch to this American dream of no pain, and telling doctors and nurses that they were unethical if they weren't getting people to this green smiley face of no pain, really was a perfect storm to just astronomically increase the amount of opiates that are out in the community. And again, we continue to do this. So pay for performance is something that has really become a big problem in the medical world, and Medicare and CMS have these Press Ganey surveys that patients get, and it asks a lot about how you felt about your care. And I'm not saying that these things are bad. I do want patients to feel empowered and to feel like they are part of their care, but these questions that were originally asked, some of these have been modified, but they ask, during your hospital stay, how often was your pain well controlled? During your hospital stay, how often did the hospital staff do everything they could to help you with your pain? Did they shoot morphine into your IV nonstop? Because they should have done that to get an A+ on this, right? That's the implication here. And so just the questions themselves are leading, saying if they didn't give you all the medicine that you wanted, then they must not have done everything that they possibly could. So we really need to have more of a a global approach to the way that we talk about these things, the expectations that we give people, and also, as I mentioned before, even though the FDA approved these, opiates are actually not that useful for long-term pain, maybe for short-term pain for in the immediate postoperative period and things like that. But the idea that I can make everybody live a pain-free life is just a fantasy, and it's causing a lot of problems with dependence and addiction. So another player that got us to where we are right now, thank you, Richard Nixon, and the war on drugs. So in the 1970s, Richard Nixon gave this very aggressive speech about how public enemy number one was drug addiction. And it wasn't the drugs, it wasn't the drug dealers, it wasn't the importing of drugs, it was drug addiction. The addicts were the problem, right? So this was the first time that we really kind of very publicly made this, use this language that was like them versus us, and there was this enemy that had to be defeated. And then all of a sudden this really changed everybody's view on people that were addicted, and this had a lot of implications for women who were suffering with addiction in pregnancy, because we have these enemies, and now these enemies are carrying babies, and oh my God, they were hurting themselves before, and now they're like hurting their baby, and this is just so awful. So the other thing that this did was really rapidly increase our amount of incarcerated persons in this country. So we have the highest rate of incarceration in this country, and a lot of that has to do with this war on drugs that really, by all measures, is totally failed. It has not helped decrease the amount of people that are using drugs. All that it does is increase the number of people that are in jail. And really, this war on drugs has been extremely racially biased from the beginning. So people of color are much more likely to be incarcerated for drugs, even though they're not more likely to do drugs. So there is a much higher rate of incarceration of African Americans and Hispanic men and women than there are whites, even though the spread of drug use is not really that different. And even if you're not so worried about the mass incarceration epidemic that we're also facing, the way that this affects healthcare is that this is a medical problem, right? We don't put people in jail for not taking their insulin or for eating candy when they're diabetic and making themselves sick or making their baby sick, right? But we do that for some reason for people who are suffering with addiction. For some reason we think that's a moral problem and an ethical problem, and we incarcerate them. And then when people are incarcerated, it's very infrequent that they have good access to addiction care as well. And so it just becomes a cycle. And then they get out of jail and they have a felony record and they can't get jobs. And then what are they going to do? So they sell drugs, or they might just get depressed and go back to using drugs. But really it's a chronic medical problem that deserves a chronic treatment. So the opioid epidemic, again, you all know this. This is nothing really new, but in 2016, 116 people die every day from overdose, and the numbers of people that are continuing and initiating misuse and abuse of opiates is really staggering. So as Dr. Shaya had mentioned before, a lot of this addiction starts with legitimate prescriptions. So 21 to 29% of people that are prescribed opiates for chronic pain will misuse them. Now, again, I want to make the point that really long-term use of opiates for chronic pain should never be the first line, and there's really not great evidence that it's actually all that useful. Between 8 and 12% of people that use opiates chronically will develop an opioid use disorder. 4 to 6% who misuse prescriptions will transition to heroin. And then 80% of people that use heroin started with legitimate or I shouldn't use the word legitimate, started with prescription drugs. So I do want to clarify this point, though. 80% of people that use heroin started with prescription drugs, but that's not necessarily that those drugs were given to them. That most of those were diverted. So I think, and I'm going to say this on my last slide, but I think a little bit of a consequence of this epidemic is that physicians have become very scared to prescribe medications and look at everybody that has pain and actually needs medication as an addict. But most people that are prescribed the medication themselves aren't the ones that are using heroin. It's their son, their granddaughter, their neighbor, whoever is accessing their prescription medications, not necessarily them. So why am I, as an OBGYN, talking about this? Well, because I care about it in general, but also because this has really astronomically or inordinately affected women. You think of, or I think a lot of people think of people who suffer with addiction to heroin as being white men, but it really inordinately affects women as well. And the rise of opiate use has increased in women much more than men. And the overdose deaths have as well. So as I said, this is mostly an iatrogenic crisis. In 2012, there were 259 million opioid prescriptions, enough for every adult in the United States to have a month's supply. Women in the epidemic, men, it's increased for 237%, and women over 400%. 3,300 women will initiate opioid misuse every day, and 31 women die every day from opioid-related overdoses. So the other thing that has become a really big problem recently is the introduction of fentanyl and carfentanil. So these are the doses that you would need to overdose on each one of these drugs, and fentanyl has really become almost exclusively what is available in Baltimore. So I don't see people tell you that they're using heroin, but most people are actually using fentanyl, even though they think that it's heroin. So the amount that you need to overdose is much, much lower, and the availability of these drugs has really just taken off because it is cheaper, easier to transport because it's smaller, and it's much more deadly. So how does this, as an obstetrician, what do I see? Substance use in pregnancy, and this slide is about substance use disorder, but really you can change the S to an O with opioid use disorder. Almost everybody that has a substance use disorder, it precedes their pregnancy. So that sounds really obvious, but it's important to think about because nobody gets pregnant and then thinks, oh, maybe now I'll start doing heroin, right? This was a problem that preceded their pregnancy, and so we need to look at this as a public health crisis and treat people before they become pregnant, but also not then stigmatize them or look down on them because they did become pregnant. Because also 80% of these pregnancies are unplanned. Women who use opiates are much more likely to have irregular periods and not know that they even need contraception. And once they become pregnant, their identification of the pregnancy is later because they just think they missed their period because they've been missing their period. So this is not purposeful that they are late to care. The other reason that they're more likely to present later to care is because they're very afraid of us. They think that we are going to report them, and even if they don't think that we're going to report them, they know that we're going to judge them, and hopefully we will not, but in their mind they know that we will judge them, and they're very scared to come and face that fact. There are also very high rates of tobacco use, and 2/3 of women with opioid use disorders in pregnancy also have mental health disorders, and these are really the things, honestly, that long-term are causing the major problems in their pregnancies. The opiates themselves don't necessarily cause major problems in pregnancies. It's all the behaviors that surround gaining access to the opiates, all the other things, the mental health disorders, the interpersonal violence, the tobacco use, and other drugs that are really causing most of the problems with their pregnancies and the being late to care. So what happens when a woman that uses drugs gets pregnant? Well, the short answer is almost every single pregnant woman engages in some sort of harm reduction. So whether that's switching the drug that she was using, maybe she was injecting heroin before and now she's snorting it. Maybe she was snorting heroin and now she's bumming bupe off of her dealer because she wants to use something that's a little bit more predictable. Or maybe she just completely switches to a different drug, or at least engages in care, uses less frequently. So even though I think that there's a very big, a lot of people that don't really understand this world look at women who are using drugs in pregnancy and think, why can't she do better? But they all really are trying to do better to whatever degree that they are able to. And some women actually do quit. But even women that quit substances in pregnancy, about 80% of them restart afterwards, which I think is a place that we as healthcare professionals really lose a lot of women because it's great to take care of pregnant women because they're motivated and it's this time in their life where they have access to care and they have this thing that is positive to look forward to. And then after the baby's born, we all of a sudden seemingly stop caring about them as a person. And so then that, in their mind, that view is that all we really cared about them for was to grow a baby, and then they did that and we discard them, and then 80% of them relapse. So women mostly understand the risks of drug use in pregnancy. Us explaining that to them over and over again is not really going to change their mind. As I said, most quit or cut back. Those who continue to use categorically have a use disorder. It's diagnostic of a use disorder. Women should really be offered evidence-based treatment rather than judged. Just a couple words, I know you're going to hear a lot about this as time goes on, but the treatment for opioid use disorder in pregnancy, medically supervised withdrawal, is really not recommended. I remember being shocked by this as a medical student and seeing somebody increasing a woman's methadone during pregnancy, but most of the time, MAT needs to be increased during pregnancy because of the physiology of pregnancy. And in my mind, I was thinking, why aren't you just switching one addiction for another? But you're really not. This is a medical treatment, and you're giving them a much more stable environment and decreasing all of those other behaviors that I explained, putting yourself in unsafe situations to get heroin, having to trade sex for drugs, injecting with needles that are unsafe, having very high highs and low lows, and constant cycle of withdrawal. And when we do convince women, there are medical professionals that convince women to go through supervised withdrawal, the rates of relapse are 90%, and the rate of overdose at the first initiation of relapse is astronomically high, and so it's not helpful for anybody. Again, I can't say this enough. This is a chronic disease that needs a chronic treatment. Making somebody withdraw and getting off of opiates for a short period of time is not a win. So the benefits of MAT, I know you'll hear about this later again, but it makes a more stable intrauterine environment so people aren't going through ups and downs and the constant cycle of withdrawal and high, which is really extremely stressful for the baby and leads to worse outcomes for baby and mom. It helps women engage in care and helps improve their maternal weight gain and their overall outcomes. Neonatal abstinence syndrome, again, I know you're going to hear more about this. The thing that I want to impress upon you is that neonatal abstinence syndrome is what we focus on in a lot of studies. You should not view NAS as a negative outcome. This is an expected consequence of women who are on MAT. So when we give you all these quotes about this % of babies had NAS, I just literally discard all of that information because I don't think, I know that NAS is not a failure. NAS in a lot of circumstances is a success. And it's important to explain that to women because when they're on MAT, when they're on methadone, when they're on bupe, their baby will withdraw, and that's okay. We know how to treat that. That was actually a success. So when we focus so much on these numbers of NAS, we really kind of miss the mark on what we're trying to do. And I have a lot of women who really try not to be on methadone or bupe because they hear their baby's going to withdraw and they're so afraid of that. But the withdrawal itself, if they're in the right place, is not actually harmful. So we need to prepare people that is what is going to be expected and not scare them about NAS. So where do we go from here? I'm sorry, I'm a little bit over time. I'm going to start going a little bit faster. Things that we are trying to do, or things that we as American society are trying to do, there are media campaigns about the risks of opioids that you probably see billboards all over the place. We are trying to increase access to treatment by increasing bupe providers and healthcare coverage. There are naloxone campaigns as well to try to decrease, like don'tdie.org, to try to decrease overdose and give some education there. And then responsible prescribing. The opioid risk tool is something that all physicians should be using before they prescribe opioids to gauge the risk that this person will become dependent or addicted to the medication. The PDMP, which is a way that you can look to see if people are getting prescriptions from other places as well, and doctor shopping to increase their opiates. This is not intended to be necessarily a positive thing that we are doing. I think someone later is talking about this, but our reporting of substance-exposed newborns in a line with the federal CAPTA law, which is the Child Abuse Protection and Treatment Act, is really something that is causing a little bit of a problem with engagement in care because we are, as mandated reporters, we are required to report the moms of all babies that withdraw. And I just told you that NAS is an expected outcome. So you come to me and I give you bupe and I tell you your baby's going to withdraw, but that's okay. I can treat it. You're going to be okay. Your baby's going to be okay. Your baby withdraws and I report you to social services. So this really causes a breakdown in the engagement in care and women's trust of the medical system. So this is something that kind of needs to be looked at from a policy standpoint. Just the last slide, tips from other countries. What are other people doing that are working a lot better than what we're doing here in the United States? In France, any doctor is allowed to prescribe buprenorphine. And when you think about it, this makes a lot of sense because any doctor can prescribe oxycodone. So we can cause the problem, but we can't treat it. You have to do a special training to prescribe the treatment, which really seems very backwards. They dropped their overdose rates by 80% by doing this, and 50% of their population who has opioid use disorder is on MAT as opposed to 15% in the United States. Universal healthcare in other countries has really helped with this. There are a lot of people that are homeless or without access to healthcare, and they just cannot afford it. And so our inability to provide healthcare to people that need it is really a problem in this country. And then really the main thing in other countries, especially in Portugal, that has helped access to care and helped people get treatment is the decriminalization of medication, or of the decriminalization of drugs, and really just the view of this as a healthcare problem and not a criminal or moral or ethical injustice. So the last thing I want to say is just that this is really a pendulum, and I think that we are getting the word out that there is an opioid crisis. I think that, on the other hand, that can swing too far in the opposite direction and make providers very scared to prescribe opioids for what they legitimately need to be used for, and can start to look overly cautious at every person and think that every person that is having pain is really just an addict that's coming asking for drugs. So I think we need to find our balance somewhere in the middle and provide access to treatment, use medications when they're actually needed, optimize medications that are non-opioids first, but really recognize how we're contributing to this crisis.